delirium. Any kind of medication or substance withdrawal can cause delirium. Infection or sepsis can cause delirium. Organ dysfunction can cause delirium. Endocrine reasons like hypoglycemia. Metabolic reasons, one of the most prevalent reasons that you most commonly see and is very easily reversible is hyponatremia. Even hypernatremia can cause delirium. Hypercalcemia can cause delirium. Dehydration in itself can also cause delirium. A lot of side effects of chemo and radiotherapy can also cause delirium. Delirium can also be because of some physical symptoms like constipation or urinary retention. So there are a number of causes of delirium. All of these reversible causes should be reversed when we are talking about delirium. Okay. Now, coming to the clinical features. Okay. Can I please request Shiva, if there are any questions in the chat, can you please let me know?
Okay, ma'am. Sure, sure.
Thank you. Thank you. Okay. Coming to the clinical features. Now, before you read the clinical features given on the screen, I wanted to go back to the definition we had discussed. What was delirium? It was abrupt onset of fluctuating confusion, inattention, and reduced awareness of the environment. If you remember this, then finding the clinical features is very easy. The clinical features, there are six specific clinical features and 5 less specific clinical features. What is more specific to delirium is that it has acute onset, like we talked in the definition, abrupt onset, right? Fluctuating course, disorganized thought, inattention or decreased concentration, impaired memory, disorientation. All these are specific clinical features specific to delirium, right? And we know all this from the definition. Now, the less specific clinical features are altered sleep-wake cycle. That is, the patient is generally drowsy during the day or sleeps the entire day and is awake the entire night. There might be abnormal psychomotor activity, altered consciousness levels, and perceptual disturbances like hallucinations, auditory or visual, especially visual, or delusions. Very important, very important for us to recognize these clinical features. Okay. Now, if we see the clinical features, a lot of clinical features overlap with the conditions that I told you are most commonly confused with delirium, or the conditions due to which delirium is most often misdiagnosed or underdiagnosed. Dementia and depression. We need to differentiate delirium, dementia, and depression. The most noted thing here, which again, if I have to take you back to the definition, if you go back to the definition, you would know, is acute, abrupt onset, right? Delirium is always acute in nature, acute in onset. Dementia is insidious in onset. It does not happen overnight. Dementia takes weeks or years together to slowly progress to this level. Okay. Depression can be variable. It can be an acute onset or it can be an insidious onset. If you're talking about duration, delirium generally lasts for days to weeks. It is most often seen in end-of-life patients, and those patients have just days or weeks left to live. Dementia, it occurs, it takes a very long course from months to years together. Depression, again, the course is going to be variable. Delirium is fluctuating in nature. Dementia is progressive, although slowly progressive, but progressive in nature. And depression generally sees a diurnal variation. It is worse in the morning and improves during the day. And by the night comes, maybe it worsens again. Consciousness levels are impaired in delirium, or they can fluctuate as well. Dementia, consciousness is clear until very late in the course of illness. Depression, the consciousness is absolutely unimpaired, right? In delirium, patient has poor memory, patient has poor concentration. In dementia, patient has poor memory, but the attention is marked, right? In depression, there is difficulty in concentrating, but memory is intact. The effect of delirium and dementia can be variable, but in depression, patient is depressed. There is loss of interest in the things that they used to enjoy earlier. Okay, so there might be overlapping symptoms, but there are also marked differences. And these differences should be kept in mind to understand delirium better. Now, when I have been repeatedly saying that we need to understand delirium, we need to diagnose delirium, but for diagnosing delirium, one very important step is assessment. We need to assess delirium. We need to screen our patients for delirium. Assessment can be done by accurate history from caregiver. We need to make sure, because we are not going to be with the patient 24/7 until unless it's a hospice. Maybe even then, even if it is a hospice, you have to be very attentive to all the symptoms that the patient has been showing. The patient might be there are types of delirium. There is hyperactive and hypoactive delirium. I'm going to tell it to you in detail after a little while. So the patient might just be very silent, hypoactive delirium. You might mistake it to be just, the patient has not been speaking much. It is okay, but it might not be. It might be delirium, which can be managed. So you have to be very accurate with the history that you collect from the caregiver. Carefully assess the patient. Clinical assessment is another thing that is very important, because you should not miss any signs, especially for the reversible causes. If the patient is dehydrated, we know that after our clinical assessment, we would know that the patient is dehydrated, and because of dehydration, the patient might have delirium, or the patient has not been eating much. We know that the patient has not been eating much. The family gives us the history that says the patient has not been eating much. That is why he's not talking to us, or that is why he's in this confused mental state. He's not listening to us. But the patient not talking to us or not listening to us might be because of hyponatremia. The patient has not eaten. Thus, there was a deficiency of sodium, hyponatremia, which led to delirium. So there are going to be small clinical cues that you have to catch for a good assessment for delirium. There are also screening tools available, like mini mental state examination, which is also called as MMSE, or confusion assessment method, which is called as CAM. Right? There is another method which is called as nursing delirium screening scale that most recently we at Cancer Support have started using and have found it to be very easy. We score the patient 0, 1, or 2 according to the symptoms that the patient is showing. And if the score is 2 or greater than 2, then the patient has delirium. We diagnose the patient as delirium. Okay, this is a screening tool, a very easy screening tool that we can, or if not this, then confusion assessment method is another screening tool. MMSE is a good screening tool, but it's a rather elaborate one. But irrespective of which tool you use, I would say that pick up a tool and use it to screen delirium, because delirium should be screened in all the patients, especially in end of life patients. Now, coming to the subtypes of delirium. There are three subtypes of delirium, three types of delirium. Hyperactive, which is also called as classical delirium. Now, hyperactive delirium or classical delirium, the classic delirium is a state of hyper aroused, hyper alert, agitated state. There are patient is going to tell you about hallucinations, delusions. There's going to be marked disorientation and agitation. Patient is going to be pulling at devices. You know, that is the hyperactive state or the classic state. This delirium, if anyone has seen delirium, they've seen most often, they have seen this subtype of delirium. But there is another subtype of delirium, which is called as hypoactive delirium or hypoaroused delirium. Hypoactive delirium or hypoaroused or hypoalert. Here the patient is either very lethargic, not responding. The psychotic features are rarely present, but the patient is always confused and often sedated, seems sedated. Now, this is most often confused with depression. There is another subtype, which is mixed. Mixed delirium is, there are going to be, it is going to be a fluctuational delirium, fluctuating between hyperactive and hypoactive state, right? So here I know that it is very easy to catch a delirious patient if that patient is in hyperactive state. If the patient starts pulling at devices, pushing people away, or tossing and turning, getting up. Sometimes the patient even start behaving abnormally, like they remove their clothes. So all these symptoms are hyperactive, and it is very easy to diagnose hyperactive delirium if you know these symptoms well. But hypoactive delirium is not that easily diagnosed because it is easily mistaken for end of life symptoms. The patient is drowsy. The patient might be getting drowsy because of end of life, or the patient is very lethargic. So the patient might be getting lethargic because end of life. Don't just label a symptom as end of life for the patient who are actually in end of life. There are symptoms, there are things that can be managed, and they should be managed. Because, remember, palliative care is not only about helping the patients symptomatically, it is also about giving the patient the dignity till they die. And managing delirium is one of the things that we can do for them. See, this is what I told you. Agitated restlessness, hyperactive delirium, lethargic and sedated or in a stupor, hypoactive delirium, and mixed delirium is somewhere in between. Now, why is delirium important? Why I have been telling you that diagnosing delirium is important, or assessing delirium is important, catching that the patient has delirium or not is important. Why? Because delirium in itself has a very negative impact on the quality of the patient's life. Whatever life the patient has remaining, that quality of life deteriorates very rapidly. The caregivers, the family who's around them, they get affected, they get distressed. And if in a hospice or in a hospital setting, the other patients also get affected. It also impairs decision making. The cognitive functions are not intact, and that impairs decision making. So when we talk about shared decision making in a palliative care setting, we need the patient's input as well. if the patient's cognition is going to be impaired, the patient would not be able to give their input. So the autonomy gets disrupted. That is why it is important, again, to manage or delirium. Okay, it also masks physical or psychological symptoms that might need addressing. The patient is so much agitated, we are not going to concentrate on the pain, right? We are not going to concentrate on any other physical symptom, which actually needs addressing. We would not be able to see that because the patient is agitated, the patient is delirious, or the patient is sedated, the patient is in a stupor or is in hypoactive delirious state. Okay, so prevalence of delirium is very, very high, much higher than it is perceived, much higher than it is diagnosed, because a majority of the patients have hypoactive subtype. A hypoactive subtype is most often missed. That is one of the main reasons why hypoactive subtype is missed, is because there is lack of awareness of this subtype. We do not know that this exists. We only know that if there is agitation, there is delirium, and this is how you are going to manage delirium. But even if there is no agitation, it can still be delirium. Now, we've talked about how to identify delirium. We also should talk about, okay, we still have to talk about how to identify delirium. Delirium, almost half the patients with advanced cancer have reversible delirium. So reverse the reversible. If you know that there is as I told you, I gave an example. If the patient has not eaten since a long time, we know that the patient might be dehydrated, or the patient might be hyponatremic. And because of this dehydration or hyponatremia, there can be delirium. So this is a reversible delirium. Reversible delirium is generally not, generally does not happen if the patient is in the last 24 to 48 hours. You will not be able to reverse the delirium. So there is no point of getting, because Dr. Ishita said repeatedly that hyponatremia can be a cause. You don't need to poke that patient to get a blood serum electrolyte up. You don't need to do that, because during the last, the confusional state, delirious state, when death is imminent, which we call as terminal delirium, is most often not reversible. Okay. Whatever is the scenario, diagnostic workup should always be consistent to the goal of care, because our main focus should always be relieving patient stress. You have to understand, if our goal of care is end of life care, if our goal is managing the patient's last 24 to 48 hours, we are going to not poke him to get an electrolyte done, or not pinch his skin repeatedly to see if he has dehydration or not. If that is not the case, then yes, get it done. Right? So always the diagnostic workup that we want to do to diagnose delirium, or for that matter, any other symptom, should always be consistent with the goal of the care you are providing to the patient. Any questions so far? Or am I going too fast, or are you not understanding anything? See, there are
No questions so far. You can continue.
See, there are no questions. It means only two things. Either everyone's understood everything, or no one's understood anything. So I hope it's the former one. Okay. Let's go towards the management. We know how to identify delirium now. We know how to assess delirium. We know what are the symptoms that we have to look for in delirium. Now we should know how to manage delirium. First and foremost part of management is going to be history taking, because if you've not taken a proper history from the caregivers, you would not be able to diagnose delirium. You would not be able to assess delirium at all. Right? Find out the cause, and if the cause is reversible, then reverse the reversible. Now coming to non-pharmacological and pharmacological methods. Explain to the patient and the relatives and the caregivers what delirium is, why it is caused, what is the likely course of this symptom, what can the caregivers expect, or what can the patient expect can happen. Very important, because if the patient and the caregivers do not know what delirium is, and if it is a home care, they will not be able to come back to you and tell you, right? We've had this is a personal experience that I'm sharing. This happened with us, that the patient, we never took a detailed history from the caregivers of the patient, and uh, after a long time, when incidentally we asked that how the patient has slept, the caregivers told us that he sleeps well, but he's always disoriented at night. He tells he always remembers things from way past when he used to live in Kolkata 50, 60 years ago. But that happens since he would be remembering all those days. That is how the caregivers informed us about the symptom. This was a very important symptom that we missed, because whenever we used to visit the patient used to be lucid. Again, I'm taking you back to the definition. The definition clearly said fluctuating. This course of illness has a very fluctuating nature. So the patient used to be very lucid during the morning times when we used to visit. Whenever we visited, patient was fine. Patient was completely oriented to time, place, and person. But patient used to get disoriented during night. So that was a thing that we would have caught way early, but we did not, just because we did not take proper history, a detailed history. Address the anxiety of the patients who have delirium, because delirium is very frightening. Since it has a fluctuating nature, they know when they are lucid that there was something wrong with them when they were not lucid. So it is very important for us to address their anxiety, to explain to them what delirium is and how it can be managed. There should be a quiet area for the patient. There should not be any loud music. Okay? Even if the patient likes music, or the family wants to put some music, tell them to put it at a very low volume. Okay? Don't change the staff. If there is a caregiver for the patient, that caregiver should not be changed very often. Or if in a hospice, the staff for the patients, for such patients, should not be changed very often, because they would not be able to recognize new faces. It will get them all the more confused. Also, very very gentle reorientation of such patients. When that patient is disoriented, if that patient is telling at 3:30 in the afternoon, if the patient is telling me abhi raat ho rahi hai, as in there's still it is night, it's dark outside, you don't need to yell at that patient. You don't tell them that no, it's not dark, don't you know it's 3:30. You don't need to say that. All you need to do is just gently remove the curtains, tell them, let's see, there's light outside, so it is not night, right? So very gentle reorientation. Don't confront, don't get agitated in front of the patient. Ensure that the glasses or the hearing aids of the patient are easily accessible, because at this time, if the patient is not able to see clearly or not hear clearly, then it will add to the confusion. Adequate lighting should be present. Adequate ventilation should be present. Provide a clock in front of the patient so that the patient can orient himself or herself with the time. Put a calendar in front of the patient. On the front wall of the patient, put a calendar so that the patient can orient themselves with the date. So try and orient, try and facilitate orientation of the patient. Don't force the orientation on the patient. Try and facilitate it. Okay. Also maintain normal sleep wake cycle. You have to make sure that the patient is not sleeping during the entire day so that the night becomes wakeful. Don't do that. Try and avoid that. Okay. Pharmacological treatment. Pharmacological treatment, these all were non-pharmacological treatments. These all are the things that you're supposed to do for all the patients. Now, if there is acute delirium, how will you manage that? Haloperidol 1.5 to 5 mg stat that can be repeated every 2 hours till the patient is sedated or the patient is calm. Maintenance dose is generally 50% of the dose required in the first 24 hours. If the patient is very hyperactive or agitated, we can add lorazepam 0.5 to 1 mg, which again should be repeated every 2 hours, or midazolam 2.5 to 5 mg, which should be repeated every hour. Remember, opioid toxicity can also be a cause for delirium, especially in elderly patients. So if you are suspecting that, again, reversible, withdraw the opioid. Hyperactive delirious patients, very easy that you will come to know that this patient is delirium. But the quiet patients, the hypoactive subgroup is the one that gets missed. Okay. Attention to the environment is also very important. If the patient is in a cold, clammy, closed room, the confusional state might increase. If the patient is able to take, until the time the patient is able to take orally, encourage the patient to take oral fluids as much as possible. The presence of a close relative or a caregiver that the patient trusts the most around the patient can help reassure him. So to conclude, if I can conclude, let's go to the definition for the conclusion once again. Delirium is abrupt onset of fluctuating confusion, inattention, and reduced awareness of the environment. Right? There are 3 types of delirium: hyperactive, hypoactive, and mixed. We should always be attentive about the causes of delirium. If the patient has delirium because of constipation, relieve the constipation, patient gets relieved, the delirium reverses. Or the patient has urinary retention, catheterize the patient, the delirium reverses on its own. The patient has infection, treat the infection, delirium reverses on its own. Hyponatremia or dehydration can be reversed. So a number of causes can be reversed. Pay attention to the causes of delirium. Consider using the screening tool for proper assessment of delirium. Early identification is very, very important and very essential for maintaining a good quality of life for our patients. And remember, I have put this point again because I cannot stress this enough. Hyperactive delirium, we will catch them very easily. They attract our attention, they attract the attention of the caregivers, and we find out that the patient has delirium. Often they are, very easily diagnosed. But the hypoactive delirium, those patients are the ones that are labeled as demented or depressed. Don't do that. Thank you. If there are any questions, there should be questions because this is a tough topic.
Thank you, ma'am. So anybody have any questions there, you can ask.
No questions. See, I told you, no questions means, yeah, finally, someone.
Hello,
Yes.
good afternoon, ma'am.
Yes,
Good afternoon.
question.
Ma'am, I had a question. Like, if our advanced cancer patient, whom we tell ki like their prognosis is we are expecting for 6 months, then they have a thought ki, like fixed thought ki they will die soon, they will die soon. Then how we can console those patients from nursing point of view?
See, from nursing point of view, or for that matter, any palliative healthcare professional point of view, you have to be very honest, and you have to give the patient and the family the entire information. Now, this information should not be given as a, don't blast a bomb on them. If this information is given to them honestly and properly, give small chunks of the information, tell the caregivers that this is what is happening. Give them the information. Suppose there's a cancer which is a metastatic, in a metastatic state. Tell them what metastasis is. Explain to them that this cancer has been spreading, and we've exhausted all curative options, or maybe the patient is very elderly and no curative options can be tried at this point in time, and that is the reason why the prognosis can be anything between this to this. But having said that, we do not know whether we do not know the timeline of any person, right? So never try and quote them, 6 months. Don't do that. No, always give them a range. Always 3 to 6 months, 3 to 9 months, whatever range is statistically proven, give them that range and explain to them that this range is not a binding contract. It is not like 3 to 6 months. It is going to happen only during that time. To explain to them that it depends on the condition of the patient, how fast the patient deteriorates, or how maybe there are going to be some good days and some bad days. You have to prepare them for the bad days. You have to cherish the good days with the patient and the family. So just conveying this information is not enough. Following up with the same patient to whom you've conveyed this information is also very important. And so as to say, consoling, you don't need to console the patient or the caregivers. You need to provide them with information in a correct way. Right? I hope that answers your question, Kusum.
Thank you, ma'am. Yes, ma'am.
Any other questions?
Other questions? Thank you. Anybody? Okay.
See, this means half of you were asleep because this was post lunch.
They are awake, ma'am. Okay, so we have a patient story. So before moving to the patient case presentation, so I'd like to highlight few points. So madam has covered most of the points. But when a patient comes to you as nurses, we have to find out the underlying cause first. So this is a major point. So you have to keep it in mind always. You have to find out the underlying cause, whether there is a predisposing cause or is a precipitating factor. So you have to find out that, and after that come to the management. So you have to try to correct the correctable. So try to correct the correctable cause. So if the patient is, madam has was telling that so many causes can precipitate delirium. So for example, constipation cause delirium, retention of urine can cause delirium, pain can cause delirium, hypoglycemia can cause delirium, and electrolyte imbalance can cause delirium. There are a lot of causes. We have to identify the cause and then try to relieve the cause first. So the second management is go for non-pharmacological management. So madam was telling clearly about what are the non-pharmacological management. For the non-pharmacological management, as nurses, is very, very important. We have to tell the patient and family about delirium is not madness. This is very, very important. What is delirium? This is not a madness. This is very, very important. You have to tell the patient, if possible, patient. Otherwise, you have to tell the caregivers. Usually, the caregivers will be thinking like that. Okay, so you have to tell the caregivers and continue the treatment with courtesy and respect. Okay, so this is the second thing. And the third thing is no restraints. So all other points you have to keep it in mind, but these 3 points, always you have to tell the patient and you have to keep it in mind usually if the patient is in the ICU settings, okay, intensive care unit, we used to restrain the patients. Again, if you restrain the patients, what happened? Again, that can cause delirium. That will be precipitating. So that is the restriction. No, so that can cause delirium. So always try to avoid restraints. So this is the very, very important thing. You always keep it in mind. Okay, so we can move on to the case presentation. Today, Ms. Latria Pui from Mizoram will be presenting a patient story. Over to you.
Thank you. Can you hear me?
Yes, yes.
Okay. Good evening, everyone. The patient details. Okay. We have a patient, 58 years of age, male patient, and he was diagnosed with CLD with GI bleeding, chronic liver disease with GI bleed. And the presenting complaints were complaint of bleeding per rectum, arterial blood, loss of consciousness for 2 days and 1 night before admission to primary health center. And he was having pallor, icterus, abdomen, distended abdomen, generalized edema, and hemoglobin was 5.5. And that time he was admitted to Pangzol PHC, which is about 4.5 hours drive from Aizawl. And so he was referred there, he was admitted there and referred here to Civil Hospital Aizawl on 26 February 2022. The history of illness was he is a known case of chronic liver disease and history of encephalopathy last year. Previous history of bleeding per rectum also happened, and he's a known case of hypertension and history of alcoholism for more than 15 years. And he quit alcoholism in 2018. And he was apparently healthy that time, but then once he quit, he started experiencing signs and symptoms. And he is a non-smoker, and he has not stopped till now. But he had no known history of allergy to any drugs and no history of hematemesis or diabetes mellitus. On physical examination, he was disoriented and pallor, icterus, generalized edema, and dry mouth. Abdomen was distended and tender, and there was ascites. Blood pressure was 100/60, and on admission to PHC, it was 60/60 and query. And pulse and other vital signs, it was within normal range. RBS was 150. And bilateral air entry was present and normal breath sounds, and there was reduced urine output. Next slide, please. Treatment and significant investigation. On 26, hemoglobin level was low and platelet also, and blood transfusion was given. And at the same time, injection Hemsil, Tranexa and vitamin K was given, and Livogard was also given with DNS, and Ringer lactate was also given. And on 27th February, the investigation showed urea level of urea was high, and sodium was low. And on 28, hemoglobin level increased a little bit from 5.5 to 9, increased from 5.5 on 26 February to 9.2. Then yes, thank you. And TLC was high, and polymorphs also, it was also high, and lymphocytes was reduced. Then PT and INR was also high. HIV, hepatitis B and C was negative, and upper GI endoscopy report was awaiting at this time when I was submitted this, but the report was reflux esophagitis and chronic erosive gastritis. And head end was elevated to 30 degree, and urinary catheterization was done, and IO charting was also maintained. The medications were given were Hemsil, Tranexa, and vitamin K, and DNS with Livogard, Repsic, IV was given 12 hourly, and Rifadox was also given BD, syrup Dufalac 30 ml 6 hourly, tablet Ditor plus OD, tablet Hep Brown 400 mg twice a day, and tablet Arsodox 300 mg was given twice a day. And then after that, Ditor was withheld, and IVF was IV fluid was changed to DNS with 2 ampoule of Livogard, NS IV, OD, and Ringar lactate was omitted. And Maltazine 10 ml was also given twice a day, and blood transfusion was again given on 27th February 2022. And injection zone 1 gram IVBD was started on from 1st March, and injection albumin, infusion albumin 20% was given OD, and sodium chloride 3% 100 ml was given, and Hemsil and Tranexa was omitted. Psychosocial aspects. Patient is unable to perform his job regularly. He is a government servant, and for the past 2 to 3 years, he was, especially this past 1 year, he was unable to perform his job properly. Remorseful of his past habits and blames self, reported by the family members, and he was unable to meet self-care. And the main caregiver wife is tired and hopeless due to the diagnosis, due to the prognosis, because they have been explained about the prognosis of the patient's condition. Daughters also take care of him, but since both are already married and they have children, they are unable to take care for their father as much as they would want to. Main concern, advanced chronic liver disease. He was disoriented, anemia and self-care deficit, prolonged stress and hopelessness for caregivers, especially the wife. Daughters feel guilty for not being able to take care of their father and help their mother at all times. Financial concerns due to prolonged illness and treatments. Summary, daily physical assessment and GCS scoring, and daily monitoring of IO charting, vital signs monitoring for 4 hourly. Basic daily hygienic care was provided, along with catheter care, feeding, preventing pressure ulcers, head and elevated, providing safety and comfort. Bleeding has stopped. HB level improved, urine output also improved, ascites was decreased, and hypertension treated. Few episodes of disorientation still present. Discussion points. What could be the cause of disorientation? How can we improve the quality of life of the patient? How can we support the patient at home? He has been in and out of the hospital for the past 3 years, and counseling for family members. Thank you.
Thank you. Thank you for the wonderful presentation. Anybody have any more questions there? You can clarify with her. So otherwise we can move on to the discussion points. Anybody need any more clarification? Okay, so nobody's need any more clarification. Okay, so we can move on to the discussion points. So we would like to hear from the participant side. So what could be the cause of disorientation? Anybody? Ma'am, over to you.
See, I told you everyone was sleeping.
Yeah. Please answer. So put your answers in the chat box.
I am waiting for the answers. I have
Yeah.
asked, I have told you, I said the definition more than 5-6 times so that you know, and you still are not answering. That means that I did not do a good job. So all of you not answering is reflecting on me.
Due
Okay.
to medications.
Due to
I mean-
medications, which medications are you talking about? Good, let's discuss this. Due to medications, okay. Which medications are we talking about?
Previous.
Can you move the, thank you.
Yes.
Okay, so these are the medications that were given. Which medication
Yes.
are you talking about? Okay, so yes, Jamilia, this is delirium. Kalaivani also says that it can be due to chemotherapy, but he's not undergoing chemotherapy right now.
Mm.
Okay, so Saraswati says that he was bleeding and his HB was low. Okay, so how are we relating the low HB to HB was not that low. He was not in severe anemia. Also, the HB was corrected, right?
Yes.
Now, Kusum Kumari says due to deranged parameters. Kusum, I want to know which parameters are you talking about? Okay, before that, Jamelia, constipation, for example, morphine. But is the patient on morphine? See the list of the medications. Okay, so Chijo says creatinine level may be the cause. Electrolyte imbalance may be the cause. Okay. Can you please go towards the investigations part where you showed me investigations? Yeah. So which electrolyte are we talking about here? Which electrolyte are we talking about here?
Ma'am,
Come on.
urea is very high, ma'am.
Okay. What else? Okay. So Kalaivani says due to Rifadak. Now Rifadak is not does not cause diarrhea. It is used to relieve diarrhea, right? It is a treatment for diarrhea. So due to Rifadak, it would not happen. Yes, Rajesh Kumar says hyponatremia. Now this was the word I've been looking for. Do you see that his sodium is just 127? What is the normal sodium level? Sodium
From
normal.
135 to 145.
Very good. So this person's sodium is just 127, and that is the reason why our patient has delirium. Oh, is it a reversible cause or not?
Yes, madam.
It's very easily reversible. So, and we also should see that on 26th, that patient was already given DNS. Yet on 27th, his sodium was just 127. So before admission, the patient's sodium would have been lower than that. Due to, and also, so Kalaivani said due to Rifadak, but let me correct you, not due to Rifadak, but the fact that he was on Rifadak shows that he had diarrhea. Diarrhea would cause dehydration. So dehydration is another cause, right? So how would you manage delirium now? I want both pharmacological and non-pharmacological management here.
Some IV fluids we can start for this patient, like RL we can give.
I said pharmacological and non-pharmacological. Kusum, this was a very straight. Tell me, what are the non-pharmacological measures that we do? What can you do for this patient? This patient is disoriented. What can you do for this patient?
Explain to family like patient is in deranged parameters, so we will give fluids and it's like of reversible causes are there, so we can revert it and start the IV fluids for this patient. And
Yes.
Monitor your patient properly.
Yes. Very good, Kusum and Saraswati. So, first of all, explain to the patient and the family that this patient has not gone mad. This patient has a condition called delirium, in which confusion happens, and this happened because of the low sodium, which can be corrected. Right? Yes, and then you treat, while you're correcting the electrolytes, what other non-pharmacological measures can you opt for? Lights, natural light. Open the doors of the curtains, open the windows of the curtains, right? Keep a clock next to the patient. Check whether the patient has any constipation or any retention of urine. Check for any other physical symptom like pain. Okay. Proper ventilation. No overcrowding with the patient. Do not try to correct the patient. Gentle reorientation. Right? These are the non-pharmacological methods. The pharmacological method in this particular patient, the only pharmacological method required is electrolyte correction. If you correct the electrolyte, you would reorient the patient very easily. Right? Now let's discuss the second point. Everyone told the cause of disorientation. We also discussed the management of disorientation. How can we improve the quality of life of the patient? What can we do?
Perhaps we can put a calendar on the wall in front of the patient so they can orient themselves by looking at the date. Or perhaps if they say it is night and yet it is day, we open the window so that they see that there is light, and then they can see that it is not night, it is day.
Yes, Antonia, you're absolutely correct. Gentle reorientation. Now, we have now moved to the second question. How do you improve the quality of life of the patient, of this particular patient? What do you do to improve the quality of the life of this patient? What is the first step? Okay, Kalayavani says, explain the treatment plan to the patient and family. Very good. Health education, yes. Shiva ma'am, do you want me to take all the questions or
No, ma'am, you can continue. So,
okay?
so we can hear from the participant side.
Yes,
Yeah.
I want to hear from the participant side.
Yeah.
And I don't want to hear the same people talking. There
Yes,
are
yes.
52 participants, apart from me and the core members, maybe 5 or 7. So 45 of you,
Yes.
not even 5 are speaking.
So others, please put your comments. So how
How-
can we improve? Yeah,
Yes.
improve the quality of life of the patient.
How do you improve the quality of life of this patient?
I'm seeing some answers coming in the chat.
Yes, the answer, the relevant answer is explaining the treatment plan to the patient and family and health education, which I agree with. Okay, pain relief.
So to participate in his ADLs.
Make him participate in his ADLs. Yes. How do you facilitate that? Multidisciplinary team involvement with psychological support. Absolutely. So see, if you're talking about improvement of the quality of life of a patient, this is a very broad discussion. Okay. But as Kalayavani and one more person, and even Hanan now said, information, honest information, that is the first step towards ensuring a good quality of life of the patient. They should know. Assessment of all their physical symptoms. Yes, Chitra says creating awareness among the family members about the disease, treatment and prognosis, plan meeting with the patient timely, and causes, also the causes of some of the drugs to work delirium. Okay. So, first of all, honesty and information. Secondly, management of the symptoms, whatever the symptoms are. Some of you rightly pointed out, like management of pain, management of delirium. All these symptoms should be managed. Management of these symptoms by correct assessment, good clinical assessment. Yes, just like Saraswati just said, complete clinical assessment and examination and counseling to the patient and family. Early identification and treatment of the reversible cause. I like this. Explain the government schemes which the client can get for economic support. Yes. Or try and make the patient, like one of you rightly said, try and make the patient participate in their own ADLs. How would you do that? Facilitate them, help them, give them small tasks. Don't tell them, you have to do all your work on your own. We are moving out. Your life, you know how to manage it. Don't do that. Explain to them, given small tasks. So today, we will not feed you. We'll keep the food in front of you. You eat. We are here to assist you, but you eat. Let the patient eat on its own. Or small things like bathing. So if the patient is not able to walk, you assist the patient for walking. Don't give the patient an easier way. We'll sponge you on the bed itself. No, if the patient wants to bathe, you encourage that person. It's okay. Come with me. Take that patient till the bathroom, bathe the patient properly. Bring the patient back. Small steps. Give the patient a glass with a straw. so that the patient can drink water or take fluids if the patient is not able to hold the glass up till his mouth. You know, small things that we can do. Anything else? Anything else that's coming to someone else's mind? Know the earlier routines of the patient and make him participate in his daily needs. Let the family know if they need any help. Just let us know. We'll be able to help. Absolutely. We reassure the patient. Improvement of the quality of the life of the patient is also, directly linked with the family. So if the family is all worried and worked up, the patient will not be having a good life, right? So it is very important to counsel the family as well and assure and reassure the patient and the family that we are there with them. Just telling it once is not going to work. Explain each thing to them, how many number of times you have to. Because you have to understand, they're going through a very difficult time. The patient is going through a very, very difficult time. Physically, emotionally, socially, psychologically, even spiritually. So we have to address all of these things. And imagine if I can tell you these 5 points like this, each point has 5 parts in the patient's brain. Can you imagine the branches in the patient's brain? How many things are going on in that person's brain? So don't stick to one thing and just think that, I explained it to them. I explained how to report delirium long back, 2 weeks back. They should know. No, they will not know. Or I told them that if there is pain, they have to call me. They should know. No, they will not know. You have to tell them again and again that if you have pain, if you have this symptom, tell me, call me. I'll be able to help. Or if you're anticipating any symptom, give the medicines to that person. That these are the medicines, keep these with you. If at all you have pain, you can take this. You can always call me, but you can take this. Right? Small gestures can help improve the quality of the life of the patient. This is a very, very, very vast discussion, but the sum of this discussion is this only. Small gestures from your end will actually help improve the quality of life of not only the patient, but the family as well. Positive reinforcement, very true. Caregiver counseling is also important so that the caregiver gives complete effort in bringing back the client. Absolutely. Treatment relieves symptoms and improves quality of life. Explain to his family about that. Absolutely. Don't let the patient suffer. Just because the patient has cancer, the pain would be there. Obviously, the pain would be there. No, the pain can be managed. The pain should not be there. So manage that. Does this answer our second question properly?
Yes, ma'am. So we can move on to the next question. How can we support the patient at home?
This patient has been in and out of the hospital for 3 years. So when they're in the hospital, you know how to support the patient. But what can you do for this patient at home? Answers. We have to poke and prod you for some time before you start typing. Home visit.
Okay. Very good.
With skincare to identify the repeated causes. Yes, very true, Manu. To identify the repeated causes, but most often in patients with chronic life-limiting diseases, there are a number of causes. There might not be the same cause repeating every time, all these years. But yes, Shirina has mentioned home visit, and I agree with that. Family support, healthy communication, family members, good relationship, absolutely. Prevent infection, fall, and pressure sores. Yes. Was this a mobile patient walking or bedridden?
The patient was bedridden.
Bedridden, yes.
Yes, ma'am.
So for a bedridden patient, nurses, we are a nursing group right now. So you will have a big list of how to take care of a bedridden patient, wouldn't you? You should know much more than I do. I should not be taking this discussion. I should be giving the answers and you should be correcting me. Teach the family members related to home care. If the patient is bedridden, we have to support wound care. Yes. The patient is bedridden, so all the pressure sore management, pressure sore prevention should be taught to the patient and the family. Do we need to go over what are the pressure sore preventions? Frequent change of position, mobilize with support. Yes. Very good.
Any other points? Okay.
Relieve pressure points by providing airbed. Very nice. Back care.
Okay.
Okay.
Then
Wound care and infection control is supposed to be taught. Very true. Alcohol Anonymous support groups. Train family members regarding pressure sore prevention.
okay. So any other points for prevention of bed sore?
Limb physiotherapy, change position second every 2 hourly, help mobilization, feeding, maintain daily hygiene, including oral care and perineal care. I just added this because this is very important.
So adequate protein support, that is very, very important. Lack of nutrition in the diet, so can cause pressure ulcer. So nutrition and hydration is very, very important. Okay. So any other points?
No, I think we are,
Oh, yeah.
we have covered all the points. Right?
So, and
There is-
also, yeah, so I'd like to add one more point. If the bed is having wrinkles, wrinkles can cause delirium. So always try give a wrinkle-free bed. Okay, and also you can do the nail care for a bedbound patients. If there is a nail tear, they can scratch on their own that skin, and that can cause pressure sore. So this is also important. And exercise. If you do the exercise, that will improve the blood circulation and we can able to prevent pressure ulcer. So we can always give a wrinkle-free bed for preventing pressure ulcer and preventing delirium.
Yes, very true.
Thank you. I think this is bed-bound patients. We can give home care support to the patients. That way we can able to support the patient and the family. So and the frequent admissions, frequent that change of environment can cause delirium. So in frequent last 3 years, this patient was admitted in between, and in between this patient was hospitalized. Maybe because of the environment change, and also this patient is having electrolyte imbalance like sodium hyponatremia. So in addition to some of the precipitating factors like environmental changes and all there, and retention of urine is also there when he was admitted in the hospital. So that was relieved. These are the main points you have to keep it in the as nurses. So so we all, you most of the time, we are the persons to look the first time for the patients. So whenever you see this type of patients, if a patient is complaining of delirium, so you have to try to identify the cause. Maybe maybe due to constipation, maybe due to retention of urine, maybe due to, like I said, underlived pain. See, if a patient is having some of the medications can also cause delirium. For example, morphine. Okay, so morphine, so one of the toxic effect of morphine is delirium. So whenever a patient is complaining of delirium, you have to, maybe usually the caregivers will be complaining the most of the time with delirium. So always try to identify the cause of delirium and treat the underlying cause. Another thing is not try to manage the delirium with non-pharmacological management, and then go for pharmacological management. Okay, so when you treat them for the pharmacological management, the drug of choice of delirium is haloperidol. First, you can treat the patient with haloperidol, and then you can add midazolam or lorazepam, as Matt said earlier. So the maximum dose
if
of,
the patient
yeah,
is agitated.
yes,
If there is agitation, then
yeah.
we add midazolam or lorazepam. Yeah, continue.
Yeah, otherwise you can continue with the haloperidol. Okay, and the maximum dose of injection haloperidol is 20 milligram over 24 hours. Okay, so so anybody have any more questions? Nobody's have no any more questions, ma'am. So it was a nice presentation, ma'am. So very good presentation. I hope all of them are have a good idea about delirium, and they can able to from this class they can I hope they can able to identify the cause of delirium, and try to manage the delirium with the non-pharmacological cause management, and then they can seek doctor's help for anyway the nurses are not an authorized person for prescribing drugs. So try to always they will try to manage the delirium with non-pharmacological part, and then go to the doctor's side, then try to relieve. If the non-pharmacological management is not help, they will get the pharmacological management. So thank you once again, ma'am. This was the wonderful session, and thank you everyone for this session is making it interactive. So thank you once again for the case presentation. So thank you, ma'am, once again.
Thank you. Thank
See
you.
you.
Thank you for
Thank
the
you.
case presentation and for the wonderful discussion. And I have left my email ID just in case anyone wants to ask. If you get a question later at night, you can always mail it to me.
Yes.
But
You can put in the WhatsApp group also. We have a WhatsApp group. You can, if you have any questions on delirium, you can put into the WhatsApp group too.
yes.
Okay, we'll try to answer that question.
Okay.
Thank you. Thank you. See you on Monday. Thank you. Take care.
Thank you all. I have shared the feedback link with you. Please go through it and fill it. And I think 5th April is the last day to submit your assignment number 3. So I think 7 or 8 of you have only completed that assignment. Please go through it and submit it at fast as you can, because otherwise the link will be closed and you cannot do the assignment. It will take a long time to reopen it again. So please go through it and do it. And thank you. Bye. We'll see you on the next class.
Do you have any difficulty for sending the assignments? Any difficulty? Any doubts or any clarification need for the assignments? No. Okay, if you have any questions or any clarification need, please call me. So my number is in the WhatsApp group. You can take my number and call me. Okay. So I'll.
Excuse me, ma'am. Excuse
Yes,
me, ma'am.
Kuzo. Yes.
Ma'am, kindly share the link for paying the amount for this course, na?
I will do it.
I
ma'am.
haven't. I
I will
haven't.
share it, ma'am.
Okay.
Okay.
She
I
will
will share.
share.
Thanks.
Okay. Thank you. Thank you. Bye. Bye.
MSP, and it is